Greetings from Indian Journal of Anaesthesia. I, Dr. Riniki Sharma, will be presenting an article published in the August 2024 issue of Indian Journal of Anaesthesia. It is titled Evaluation of ultrasound-guided suprazygomatic maxillary nerve block in functional endoscopic sinus surgery for postoperative pain relief, a randomized controlled trial. Functional endoscopic sinus surgery or FES is the standard for treating sinonasal pathologies but causes mild to moderate postoperative pain. NSAIDs are commonly used to reduce the pain after FES, but they have side effects that can delay the recovery and discharge. Regional nerve blocks have become increasingly popular as they provide better postoperative pain control, manage complications, and promote rapid recovery. The pain that occurs after FES surgery mainly arises from resection of facial bones around the nasal cavity, with the maxillary nerve being the primary source. The suprazygomatic approach to maxillary nerve block have been used in FES patients but has not been specifically evaluated for these surgeries. So this study hypothesized that supplementing general anesthesia with ultrasound-guided suprazygomatic maxillary nerve block would improve the post-operative pain relief after FES compared to general anesthesia alone. So the primary objective was the post-operative pain scores using NRS between the two groups. The secondary objectives are total 24-hour post-operative rescue opioid consumption, time required to give the suprazygomatic maxillary nerve block, surgeon satisfaction score, post-operative hemodynamics, and post-operative complications between the two groups. Institutional Ethical Committee approval was taken and the trial was registered in CTRI, and all adult patients of 18 to 65 years with ASA grade 1 to 2 for FES were taken as participants. These study excluded patients with known allergies to local anesthesia, infection at the puncture site, neuropathy, bleeding disorders, and chronic renal diseases. Randomization was done using computer-generated random number table, and the participant and outcome assessors were blinded. There were two groups. In group B, GA plus ultrasound-guided suprazygomatic maxillary nerve block was given. In group C, general anesthesia alone was given. And in the group B, general anesthesia block was given after inducing general anesthesia in the patient. So 1 day prior, a pre-anesthetic checkup was done. The patients were explained the numerical rating score. They were kept NPO. Alprazolam and tablet ranitidine was given as pre-medication. In the OT, on the day of surgery, the standard ASA monitors were connected and IV fentanyl 2 mg per kg was given, and the patient was intubated with propofol and atacurium. After that, in group B, the ultrasound-guided suprazygomatic maxillary nerve block was given by keeping the patient in a supine position with the head turned toward the side of the block and faced upward. A curvilinear ultrasound probe was kept inferior to the zygomatic arc and angle 45 degrees cephalad to image the pterygopalatine fossa between the maxillary anteriorly and ramus of the mandible and pterygoid process of sphenoid bone posteriorly. The puncture was estimated at an angle formed by superior edge of the zygomatic arc below and posterior orbital rim forward. A 22-gauge spinal needle was inserted and directed 45-degree caudal, 100-degree anterior and advanced 50 mm. The needle tip was visualized near the anterior end of the lateral pterygoid plate. After that, 5 ml of 0.2% ropivacaine was slowly injected after negative aspiration, and the correct position of the needle tip was confirmed by spread of local anesthesia in the pterygopalatine fossa. The anesthesia was after that maintained with oxygen 60% nitrous oxide and isoflurane with a MAC of 1 to 1.2. If the mean arterial pressure increased by more than 20% of the baseline, fentanyl boluses were given, thinking to be as pain. And if decreased to MAP was less than 20% of the baseline, normal boluses was given, followed by IV mephentermine 3 to 6 mg boluses if required. Before the completion of surgery, paracetamol 1 gram was given, and the patient was extubated after giving neostigmine and glycopyrrolate. Total duration of surgery was noted. In the recovery room, diclofenac 75 milligram was given as rescue analgesic in patients with NRS more than 3 or if the patient demanded it. If no improvement was seen even after 30 minutes, IV tramadol 50 milligram was given up to 6 hours of surgery. The total rescue dose of analgesic was noted. All patients received tablet paracetamol 500 milligram 8 hourly. Tablet diclofenac 75 milligram was given as a rescue analgesic at 6 to 24 hours. The pain was assessed at 30 minutes, 1 hour, 2 hour, 4 hour, 6, 8, 12 and 24 hour postoperatively. Hemodynamics was noted every 15 minutes and the time to perform block was defined as ultrasound imaging to drug deposition. The surgeon's satisfaction score was evaluated in a 5-point Likert scale, with 1 being very bad and 5 being excellent. So the primary outcome was NRS for static pain in the immediate postoperative period. The secondary outcomes were total 24-hour postoperative rescue opiate consumption, the time to block, surgeon satisfaction score, postoperative hemodynamics, and postoperative complications, if any, like nasal bleeding, headache, nausea, vomiting, cheek edema, or swelling. The sample size was based on a previous study where blocked by intraoral greater palatine approach after FES, the mean postoperative pain score was 4 with standard deviation of 1.26 in the control group. Assuming 25% reduction in the suprazygomatic maxillary nerve block in the pain scores, the sample size was calculated to be 22 per group at 95% confidence interval and 80% power. Taking 10% dropout rate, the final sample size was 24 per group and a p-value of less than 0.05 was considered significant. So this is the consort diagram. 60 patients were assessed for eligibility, after which 24 per group were analyzed. This is the table showing the baseline demographic characters between group B, that is the ultrasound block group, and group C, that is the control group, which is similar. So the primary objective was the NRS score in the immediate postoperative period, which was significantly less in the block group compared to the group where patient did not receive any block. Also, we can see that the NRS at all time points was significantly higher in the control group up till 24 hours post-operatively. In secondary objective, there was no difference in the intra-fentanyl requirement between the two groups. The patients in the block group did not require any rescue analgesia. The mean time to perform each block was 485 seconds. 8 patients were given IV diclofenac as rescue analgesia within 1 hour in the group C, that is the control group. And the postoperative heart rate was significantly lower in the block group till 2 hours postoperatively. There was no significant difference in the MAP, mean arterial pressure, between the two groups. There was no statistical significance in the median surgeon satisfaction scores. One patient complained of mild numbness around the cheekbone and blood was aspirated in one patient in the block group, while one patient complained of nausea and vomiting in the control group. So this study showed a significant reduction in postoperative pain with suprazygomatic maxillary nerve block, not only immediately after surgery, but also till 24 hours postoperatively. The block's efficacy is likely due to the inhibiting nociceptive impulses from the maxillary nerve and that prevented both peripheral and central sensitization. The pterygopalatine blocks targeting the maxillary nerve and sphenopalatine ganglion block have been used for postoperative pain in FES and other facial-maxillary surgeries. But unlike previous studies, using intraoral or intranasal routes for sphenopalatine ganglion blocks, ultrasound-guided suprazygomatic maxillary nerve block provided a more reliable block of the maxillary nerve, ensuring excellent analgesia post-FES. The suprazygomatic approach uses a surrounding bony anatomical landmark to navigate the needle safety, minimizing risk and ensuring higher safety compared to infrazygomatic approach. This study observes no serious side effect from the block, aligning with previous studies. The limitations of the study include a small sample size, a 24-hour observation period, omission of pack removal pain, and lack of objective disease severity and extent of surgery consideration. Different surgeons performing the surgeries might introduce bias. So further studies are needed to validate and generalize the findings of this study. So from this study, it can be concluded that the ultrasound-guided suprazygomatic approach to maxillary nerve block provides excellent postoperative analgesia for patients undergoing functional endoscopic sinus surgery without any significant side effects. Thank you.